teaches at the Department of Family Medicine at Dalhousie University and the Nova Scotia Trauma Program, while continuing to work with the Emergency Health Services as an online and medical oversight physician. This means he gets calls around 3 or 4 in the morning. He has worked to improve health literacy and access to care with local First Nation communities since 1990 and continues to provide care and consultation services to rural and remote areas in Nova Scotia through unique collaborative partnerships. He was the senior He was the senior physician advisor, I worked with him, for the Nova Scotia Department of Health and the former director for quality and patient safety for the department from 2008 till 2010. He currently is the medical director for Medavie EMS, which helps oversee paramedics in Nova Scotia, New Brunswick, PEI, and Ontario. Dr. Buchholz will be talking about integration, health equity, cultural competence, and the Provincial Domestic Violence Action Plan. Welcome, Ken.
Thank you very much. It's a real pleasure and an honor to be here, and a wonderful job to the organizing committee for doing this. It feels very much like being home again, actually. Looking at some of the folks around the tables from the old Department of Health at that, David Gass and Daryl and Sandy and Sharon and Shane, if you're still there. It's really been great to see you all, and Dennis back there too. In fact, the last time I think I stood up here and seeing all those folks and those friendly faces we were in the middle of H1N1, the pandemic. So it's probably just as appropriate that I'm talking about the pandemic of health inequality and cultural incompetence and the increasing domestic violence that we have, if you want to call that a pandemic. So I was asked to kind of integrate everything and kind of do it from the perspective of, as a primary care practitioner who sees people on a daily basis, seeing people coming in the office, as was pointed out earlier, bearing all your dirty secrets, giving us some of those most difficult things that trouble you, just rattling the skeletons in the closet, trying to do that in an environment where it's fast, it's rushed, there's other people coming in and so on and so forth. And it's not an easy task whatsoever. And I'd like to thank the table that I had out in the back there as we were working on those questions that as we went through this. And it's very much some of the things that I wanted to touch on, all in 10 minutes or less. So I just wanted to go over just a couple of quick little things, and these are actually cases based on real situations actually that have occurred within the last month in my office, and any references to names and situations so on are of course purely by coincidence. The Ballad of Jack and Diane, and no, I'm not going to sing that. I will. Yes, Sandy knows. So Jack's a 50-something retired government employee, actually formerly with the Armed Forces, used to be a regimental sergeant major. Diane is his 50-something housewife, part-time housekeeper. They've been married 30 years. They married fairly young at a military base years ago in Ontario. Regrettably, Jack likes his liquid refreshments. Perhaps a little bit too much. Controls all the finances, always has. And his pension brings in most of the money. And he likes his trucks, he likes his toys, he likes his power tools. Diane has been trying to make ends meet, trying to hold the household together, raise the family. The kids are now gone and they've left the nest. But Diane just needed a little bit of money, and he wasn't giving her much more than a very small stipend, literally an allowance to try to get by. So she used to work at the local some of the local establishments as a housekeeper, get her own spending money and do her own thing until she developed a debilitating brain disease. So Diane was no longer able to work, she was no longer able to drive, she was solely dependent on Jack for all the transportation, all the support, and of course, dwindling amounts of resources. And not that they needed it, but they just went out and bought a new truck. And it's really put everything into crisis. She shows up in the office and she has increased dizziness, increased problems, totally out from what I would have expected from her brain disorder. And I'll let you kind of mull over that situation, kind of where we can go from there. So the other situation, this actually happened while I was in Emerge a couple of weeks ago, actually. A situation where one member of the family fired the rest of the member of the family. Said, I'm not fired, you're fired. And they said, well, we're not fired, you're fired. So it was George, we'll call him George. George is an 86-year-old fellow, retired railway worker, and we'll call his wife Georgette. She's 84, housewife, retired teacher, and his wife of 50 years. So Georgette has failing memory herself. She's got quite significant spinal arthritis, stenosis, and she has a great deal of difficulty walking and caring for herself, let alone anyone else in the family. She's become pretty much dependent on the rest of the family to look after her. So family has become increasingly concerned, though, about their mom's disabilities. They fear for her safety. She's always getting up. She's always getting up and trying to go out to the kitchen and get a glass of water. She comes, and of course, she doesn't take her walker or any of her canes, and then she takes a little trip and fall, and down we go. We've already broken a hip, we've already broken a wrist. Family's getting overwhelmed because she's calling, she's calling, she's calling. And one day, the call went to 911, and the ambulance picked her up because she needed help. And she came in, paramedics shaking their head, not sure what's going on. Family coming in saying, we've had it up to here, we can't stand this anymore. And she's all the while very quiet, very passive. So I do the examination, fortunately find nothing too much amiss other than what we already knew was going on. Spoke with the family, found that they were immensely overwhelmed at the care requirements. And they said, it's time. Mom's got to go in a home. It's time. It's time. I'll go back in and speak with Georgette. Georgette, what's happening? And she said, so basically in our good Newfoundlandese, Lord God, thunder and Jesus by. It's about time somebody asked me what's going on. She said, I'm sick and tired of everybody telling me I'm demented, I'm crazy. Yeah, my memory's not that good. And when I did her mini mental status, it was actually 26, which is not half bad for someone in that situation. So she wasn't grossly demented, as I'd been told by the family. So Georgette's like, you know, every time I call out, I just want a glass of water, and nobody comes and gets it for me. I call, I just want a little bite to eat. I can't get up and do it myself. And I get some water, and then I got to go pee. And then nobody comes to help me. And then I wets the bed. And then I call for more help, and they don't come. So I get up, and I go out, and I go try to fix it myself. And well, that's what happened the last time I broke my hip. I took a tumble and went down, and of course, ended up in hospital and so on. In essence, her family fired her, but she, in turn, said, I want to go to some place where people will pay attention to me, will look after me, and where I can socialize with people. I'm locked up in the house. I can't go anywhere. They don't let me get up. If I get up, they treats me rough. My son pushes me back into the bed. You know, I asked if she's been struck or abused in whatever way, and no, nothing like that. But I've been treated rather rough, Doc. I've been treated rather rough. So just something to mull over, you know, really, really quickly. And surrounded by a group of psychologists and social workers and professionals in the field. I'm not going to go into Maslow's hierarchy of needs. You all know that really, really well. But I'm just going to say the bottom two is all I want to focus on. The bottom two, if you haven't got that, you haven't got anything. At the very least, you need to have a roof over your head, some food on the table, some water, some basic things to look after yourself. Well, heck, I guess those who are even rough out in the woods will have that if you get a tent and so on. But then if the wolves are circling outside, or the bears are there, or there's someone else in the household who's acting like a wolf or a bear, you're not going to feel safe. So if you haven't got those bottom two rungs on the ladder, you really don't have it. And when we look at some of the situations that I just spoke to you about very briefly, hypothetical sort of as they are, you realize that some of those things Georgette really didn't even have that first rung there, the food, the water, and that sort of thing. She certainly didn't feel Perhaps she felt safe in the environment that she was, but she certainly wasn't in a situation where she was thriving, socially active, interactive, and so on. And when we look at Diane in that situation, Diane sure had the roof over her head and so on and so forth, but she certainly wasn't in a situation, she had needs, she wanted to get out, she wasn't supported, and she didn't know what else to do. And she saw the savings disappearing on frivolous things, and she had no way to stop it. And she'd been told many times, why don't you just leave? And I suppose we could all turn around and say, well, why doesn't he just change his ways? And those are easy things to say, but a whole different way, a whole different issue when we're looking at trying to make that work. I'm not going to go through, we know that domestic violence is a very significant problem, and you've talked about that today, so I won't go over all that. But some of the tools that we have for our professionals, and I'm just going to run over, I work with the Nova Scotia Trauma Program, and I do teach quite a little bit on that little section that we have on domestic violence. So it seems everything in medicine is 3 questions. You got one problem when you go in and see a doctor, but we only give you 3 questions. And those 3 questions, you ever been kicked, hit, punched, or otherwise hurt by someone? Do you feel safe in your current relationship? And is there a partner from a previous relationship that make you feel unsafe? And those are kind of posted on a lot of emergency walls. It's kind of thing drilled into medical practitioners. And that's about it. So how effective is that? Now for me, whether we're talking about domestic violence, I'd like to really couch the whole thing in the sense of just health equity in general. It's about lack of access. And if we don't have access to practitioners that A, have been trained appropriately, B, have the time to make things work, in an environment where people can get in fairly quickly, can get in, if you need to be seen and follow up, great. I mean, if my doc can't see me for 6 weeks, then my follow-up appointment can't be for at least another 6 weeks, which isn't going to be helpful for some of these things. And I'm going to go into their office with 12 different things on the agenda, because that's the only time I'm going to see them in 6 weeks. So it's a challenge trying to get the access, and none of those wonderful plans that we have in place will work if the system does not create the environment to support success. In order to train our practitioners to understand what's going on, to train that there's different ways to do the scheduling, having an open access, advanced access, whether you want to call that same day, next day, but some sort of a process to get people in very quickly and have the follow-up. And to also understand what their biases and their preconceived conceptions may be. One other thing I'd like to leave you with as a final point is that for all of us as practitioners, for all of us, that every encounter with a patient, client, someone else looking to us for help is really an exercise in cross-cultural awareness and work. There are authority issues. Any one of you stepping into my office, I'm sitting in the captain's chair, I'm a male, and I'm going to talk to you about really, really important things to you that some of you may not even wish to share with your friends and family. There may be physical contact. We talked about, someone mentioned earlier, a male doing a pelvic exam on a lady who, in their culture, that's just not a go. Being aware of that. The various communication styles of dogs. How many here have family dogs where it says on the wall, one problem? Well, then that one problem better be that I'm being abused at home. But you know that's not what it is. It's, I have a sore throat, or I have belly pain, I have back pain, I have menstrual problems, I have something else going on, and that's your segue in, but woo, that segue was your problem. Gender, sexuality, whether family's in the room. Great to have family in the room sometimes, absolutely phenomenal to have family in the room to give you a background, but not if the family is causing you some grief. And miscommunication often. So the final things I'd just kind of like to leave you with on these. When you're interacting with anyone, asking for your opinion or seeking assistance, just kind of remember to, number one, slow down. Try to use your language as plainly as you can, recognizing that not everyone has the same education background that we may have. Pictures if necessary. Interpreters if there's a language issue. using pictures, whatever you can. Keep the information limited. The KISS principle, all right, it's keep it super simple. All right. Use the teach back technique. So when you go home today to tell your spouse or friend or family what it is that Buckles told you about today, what is it that you're going to tell them? All right, so kind of get them to teach this back to you. And where possible, work toward an accessible, shame-free environment where people can call you, feel comfortable, feel free that they can sit down with you and chat with you like that you were their next best friend. Encourage questions, encourage interaction, and try not to, move the interviews along too quickly. And with that, I will leave you, and hopefully I've been able to integrate some of those issues for health equity and cultural competence, bring that all together in one thing, as a practitioner in the primary care environment. Thanks very much.